Clinician Support Across Settings by Mark Blazey, in collaboration with the Institute for Professionalism in Ethical Practice.
Hello, my name is Mark Blazey, Certified Registered Nurse Anesthetist. I am here to briefly discuss organizational support following an error or adverse event. In this video, I will review some formal and informal institutional resources, as well as independently sought resources that different organizations have developed to help their clinicians deal with these difficult situations. I'll skip right to the punchline of this talk. Study after study shows that organizations as a whole actually reinforce negative and pervasive feelings experienced by a clinician, rather than help them in their recovery. They are generally poor at providing positive emotional support, and fewer than 20% of clinicians receive any form of support from their institutions. Additionally, the majority, 66% of clinicians, believe their organization responds to error in a punitive and non-supportive way. To combat this problem, organizations in the United States have developed a variety of support systems, which I will run through briefly. While this is not an exhaustive list, the variety of formal, informal, and independently sought programs presented here should help guide an organization of any size and resource capabilities to provide their employees with the support they require. Some formal institutional support systems include intra- and interdepartmental morbidity and mortality rounds, peer support groups, employee assistance programs, emotional rapid response teams, emotional hotlines, post-event team debriefing, risk management, quality assurance, and quality improvement processes, peer patient safety committees, and patient death and family discussion simulators. Informal support systems include discussion with other personnel or colleagues, time away from clinical duties or roles, and ethics consult. Some, but few organizations do have a formal policy regarding time away from clinical duties following a catastrophic patient event, which has been shown helpful for the clinician and for patient safety. Independently sought support services include talking to one's own spouse or family, social work, chaplaincy, psychiatry, counseling, and a program entitled Medically Induced Trauma Support Services, or MITS. None of the formal, informal, or independently sought resources can or should stand alone as a method to provide adequate emotional support. For instance, an ethics consult can be useful to reassure the clinician their role is within the protocols and supported by the hospital, while the morbidity and mortality rounds can provide a clinical reinforcement that a poor outcome may not have been the fault of the provider, and time away from clinical roles can give the necessary time away from clinical duties to recuperate and emotionally recharge. Doing better first involves recognizing the problem as illustrated in this graph. Ignoring or denying the lack of resources and major stressors following an adverse event perpetuates the problem, the isolation, and feelings of guilt so many providers experience. Any institutional resource requires time and training to implement. Doing so before an event is critical. I urge you, as someone who has taken the initiative to participate in this course, to take action and help your organization and your peers by finding a set of programs that can work in your setting. In summary, a real need exists for an organized emotional support institutional response following medical errors and adverse events. Institutions across the U.S. have a variety of types of resources to suit the different needs of the person or people involved, as well as the situation and event itself. Deciding on and investing in a system of support is necessary before an event occurs.
Reflective exercise. Please post your responses on the comments board for this video so that others may learn from them.